Monitoring microcirculation is very useful. I'm Jacques Duranteau from the Department of Anesthesiology, Intensive Care and Perioperative Medicine from Paris-Saclay University. I have no conflict of interest. So the ultimate goal of resuscitation is to improve tissue oxygenation and to improve microcirculation. Currently, we are optimizing macrocirculation hemodynamic parameters, especially arterial oxygen transport, with the hope that we will optimize microcirculation. Most often, this is true because there is a physiologic link between macro and microcirculation. So just to illustrate this, in this study where we look at microcirculation during surgery, during major abdominal surgery, and we look at microcirculation during preload dependency period, and you can see that during this period we have a decrease in mean arterial pressure, a decrease in stroke volume index, and concerning microcirculation, we have a decrease in its sublingual microcirculation. We have decrease in microvascular flow. We have a decrease in the density of micro vessel and an increase of the heterogeneity index. But when we perform a fluid challenge, we improve the stroke volume and we improve all the microvascular parameters. So clearly there is a link between macro and microcirculation. It's interesting to note that microcirculation, even if it's only a sublingual microcirculation, can alarm us on the fact that we have a decrease in stroke volume index. But in more severe situation, for example, tissue hypoxia or pathogen with exogenous PAMPs and endogenous DAMPs release with host product inflammatory mediator and product released by rhabdomyolysis, we can have alteration of microcirculation through change in viscosity, endothelial and glycocalyx injury, alteration of red blood cells. And in this case, it's possible to lose the connection between macro and microcirculation. And in this case, when we try to improve macrocirculation, we are not sure to improve microcirculation. This has been nicely demonstrated by Daniel De Becker in septic shock. You can see that in this septic shock, when you look at during early period within 24 hours of the onset of the sepsis, or during a late phase, after 48 hours of the onset of the severe sepsis, despite the fact that there is restoration of macrocirculatory parameter, microcirculation is still altered. And what was the most interesting is that only microvascular parameters are capable to predict mortality in this patient. Only the percentage of perfused vessel was capable to predict mortality, and lactate was and SVO2 was not capable to predict mortality. So clearly, it's the proof that sublingual microcirculation, even if it's not the reflect of all the microcirculation, is very valuable parameters to detect severe situation, to detect a persistent hemodynamic problem or a persistent sepsis. So we demonstrate a similar link between alteration of microcirculation and the multiple organ failure in hemorrhagic shock when we show that the severity of the alteration of microcirculation was linked to the multiple organ failure in this patient. This has been also demonstrated in hemorrhagic shock in trauma patient by etching the same result with only microcirculation parameter capable to predict the development of multiple organ failure at day 7 in this patient. So just to insist on the fact that we are totally blind to microcirculation and that this has a potential impact on the quality of your resuscitation, we look at that in the septic shock at the level of the kidney, of the cortex of the kidney. We use to monitor or to look at microcirculation, we use the contrast enhanced ultrasound technique at D0, D1, and D3 after the admission in ICU. And what we observe is that despite the fact that we restore hemodynamic in this septic patient, we observe very different profile of cortical microcirculation in this patient. In some patients, the microcirculation was, compared to control, was normal. But in some patients, we observe a clear alteration of microcirculation. And in some patients, we observe a very high flow. So for me, it's clearly illustrated the fact that it could have an impact on our strategy, because in this patient where I have an hyperdynamic flow, I have not to give more fluid, but in this patient where I have an alteration of microcirculation, maybe I have to give more fluid, maybe I have to increase the arterial pressure to try to improve the microcirculation at the kidney. And so clearly, in comparison, in this study, in comparison to the control group, clearly the microcirculation at the cortical kidney level was altered in septic shock, despite the fact that we have a restoration of microcirculation. And also a very important result is that people who develop an acute kidney injury had a more severe alteration of microcirculation at the kidney cortex. So in conclusion, during the initial phase of shock, it is reasonable to assume that the relationship between macro and microcirculation are still preserved, and improvement in microcirculation will be obtained by increasing systemic oxygen delivery. However, shock or more severe situation or other severe situation can damage microcirculation and then lead to a loss of relationship between macro and microcirculation. Guiding therapy strategy on microcirculation can lead to more individualized and relevant resuscitation. So clearly for me, in the future, the monitoring of microcirculation is a fundamental step toward the individualization of our care. To explore the relationship between macro and microcirculation and to perform target microcirculation study, physicians need real-time technique at the bedside to monitor microcirculation. Thanks a lot.